I'm originally from Brazil. You can realize it by my funny accent. It never goes away. And I was living in Germany for 2 years when I finished my training. Actually, it was a second postdoc in neuroanatomy. I did a residency in pathology, and then I decided to specialize in neuropathology, which I did. So I also pursued a PhD program in neuropathology of dementia and aging. I did it partly in Brazil and partly at Washington University in St. Louis, where I had part of my training. Back in Brazil, together with other colleagues, we, in 2003, opened a brain bank specialized in aging. And the goal of this brain bank would be to collect cases from people older than 50 years of age, but mostly cognitively normal people. And we decided that Brazil would be a very good place for doing that, because in this country, autopsy is mandatory. So theoretically, everybody has to be examined after death. And there are some exceptions, but as a rule, almost 60% of the population is examined, which is really something unique in the world. And in São Paulo City is a very big city. We have about 12 million inhabitants, and there is just one place to conduct autopsies of natural death. It's not coronal autopsies, not violent deaths, nothing like this. But it means that we perform 13,000 autopsies per year, and 60% of these subjects, they are older than the age of 50, making a very impressive and important facility for research. Therefore, we set a project, we got it approved by our IRB, and we have a group of very engaged nurses. They are trained to approach the family when they go to the autopsy service to release the body. They have to go there. And autopsy is mandatory. We can understand how important it can be for public health, but it's very difficult for the family to imagine and to, that their beloved person will be submitted to autopsy.
Yeah. Lea, excuse me.
Yeah.
Sandy.
Excuse me.
Oh, sorry.
Noisy enough as it is, and now I've interrupted you.
Sandy Watts, Dr. Lea Grinberg.
Thank you for
And because of this, usually when we approach the families and ask for a donation, they really, it's not only that they accept doing that, but they are happy to do, because they realize that they can make this very traumatic experience that is to have an autopsy in a beloved person, something that will contribute to science and contribute to other people's health. People in Brazil, they are very friendly in general. We have a rate of acceptance of 96%. We don't collect all the cases because we have no means to process them in the proper way. So since we get this donation, we feel that we have to treat these donations with care, and we really have to submit the brains to a very careful examination. So it's not, there is no use to have 10,000 brains per year if we have no hands to deal with this. We are collecting today an average of 400 brains per year. 75% of our sample is composed of of normal people. They have no dementia, they have no mild cognitive impairment, nothing like this. And we know it because since this family is there, and usually the whole family goes there, we can identify a primary caregiver in Brazil. People usually are treated at home, not at senior houses, so it also makes it easier for us. And we take them to a private room and apply a series of interviews that has been created here in the US for caregivers. We apply, it's about, I think it's 9 instruments so far, plus an interview, and because these nurses, they are engaged and they are very well trained, we know that the data is very reliable. Of course, we had some studies comparing this data with the data we get with inpatients and outpatients that we can examine the person. So of course, we don't have a longitudinal follow-up. This is one of our limitations, but we believe that we have the best we can get making use of this incredible facility with the cooperation of these wonderful families that donate their brains. And now I can go to the second step. So since we have this amazing collection of information and these donations, we could propose some studies which are not very difficult to do in terms of methodology. We have also, of course, limitations in Brazil, but that can answer very fundamental questions in dementia or in Alzheimer's disease that couldn't be answered using very sophisticated methods in other places of the world, especially here in the US and in Europe, where we could apply these methods, because we don't have the brains. As everybody knows here, it's so difficult to really engage people in post-mortem studies. And usually when we do, most of the people that engage in these studies, they had a very severe dementia for many, many years. It's very difficult to look at what is going on in the beginning of the disease. We also know that about 25% of people who don't have any kind of clinical manifestation, if we look at the brain, they meet neuropathological criteria for Alzheimer's disease. And these people are very precious for us. So what do they have that protect them to express clinical symptoms even if they have the disease? Because what they can tell us that even if we can't cure the disease or it will take a long time, at least if we can identify risks and protection factors that make us protected against the manifestation of this disease, it will be very good. The person will be active and the society will be independent for a longer time without so much effort. We know, for instance, that years of education, more years of education, is a protective factor. A person who has the same amount of disease in the brain with 10 years of education is likely to function better in the society than a person with the same amount of pathology but less years of education. It has been shown here, especially with the NAN studies and some other studies, and we've shown this in Brazil because there the population has a very low educational level. So we could compare people who had 0 years of education, 1 year of education, and 4 years of education and more. And we know that this cutoff 4 years, which is not very much, really gives a protection to the person. We could also examine other fundamental questions regarding these cognitive normal people, compare people who has Alzheimer's disease in the brain but do not manifest and people who doesn't have. And one of these questions that we have applied for this, we submitted this proposal to the grant call of the Alzheimer Association, and we were very glad that we have been chosen, is we would like to understand what is the role of ethnicity in expression of the dementia. So again, if we take two people of different ethnicity and they have the same amount of pathology in their brain, will they express the same kind of clinical manifestation if we control for education and APOE? I mean, if we try to take people who are similar in all the other aspects but not ethnicity, is there any kind of protection or risk factor? And why is important for us to know this? We know that Alzheimer's disease is mostly an environmental disease, but it has some influence of genetics. maybe the genetics is not more predominant, but there are some things that cause some higher risk, for instance, ApoE. But maybe there is some other thing that maybe Africans have more than Caucasians or so on, that we could indirectly try to identify if we can identify differences in ethnicity. So it's not the ethnicity per se that will protect, but something that comes together with ethnicity. We had a problem to do that. The population in Brazil is admixed. Although we have 70% of Caucasians and about 11 to 15% of pure Africans descendants, let's put like this, people are very admixed. Sometimes they call themselves Caucasian, but the grandfather was African, but they look white. It's a problem for us. Therefore, we had in our studies genetical analysis for ethnicity. We take the DNA of these people and we submit to a series of examinations. They call ancestry identification markers. We test 70 of them, and then we can have a curve of how much African this person is, how much Caucasian, how much Asian, but not only African. We can distinguish between 10 different African groups. We can distinguish between 4 Caucasians groups. For instance, we can distinguish between Caucasians from Europe and from Middle West. And they look alike, more or less. And so on. So we think that this approach is it's very important for our studies. We propose to study 507 cases, 160 pure Africans, 320 Caucasians, and it's about, I think it's 47, 57 Asians, because we only have this amount of Asians, but even though it's more than many other banks. And so far we finished the analysis of the first 350 cases. And what we found in our preliminary analysis is that indeed Africans, when they are exposed to Alzheimer's disease, they express the symptoms before Caucasians if we control for all the other factors. And indeed, it goes in line with some epidemiological studies that we have here, showing that African populations, they have a higher risk. We are trying now to analyze Caucasians who are from Northern European countries, from Caucasians who are from Southern European countries. It will be like Latino versus Caucasians, and the same kind of Caucasians we would have here in the US and Northern Europe. And we can do it in São Paulo because of all these immigrations we had there. So it's a great place to study.